the New England Dry Eye Center, we have a certain protocol for evaluating and then documenting and following the course of our patients. The first is to start with the referral note either from the physician that sent it in or from our own previous medical records so that we have information about the patient that we can readily access. There's also a patient history record that is a more general form that the patient fills out with who their doctors are, what medicines they're on, what past medical history is otherwise documented. We then start with the speed questionnaire, and this can be in any doctor's office, but if they don't have it in their office, when the patient comes in referred, we have them fill one out here. The speed questionnaire asking the basic symptoms and frequency and severity of their problems. This is scaled on a 1 out of 28 or 0 out of 28 basis. We usually find that if it's 6 or more, we want to recommend evaluation. If it's less than 6, then we think somebody probably doesn't really have enough of a problem to warrant our type of evaluation. We then start a dry eye testing, and that begins with that speed questionnaire where we have the completed result on that scale of 0 to 28. We then make sure that we've reviewed the chart and have a history of their treatment. We do measure their vision. If appropriate, there may be some additional corneal topography and or some degree of keratometry just to have an idea of what their corneas look like. And intraocular pressure is important, particularly if they've been on or may be on steroids for any period of time. A lip of view is done, and in the case of a lip of view, we do ask them, as per the instructions of the company, not to have used any recent artificial teardrops, ointments the night before, wearing of contact lenses 4 hours before, etc. After the lip of view is taken, we then will document the numbers from that lip of view. We do look for partial blinking on the lip of view, and that is made a note by the technician. The doctor's exam prior to lid touch includes the general appearance of the patient that might include things like rosacea or if they've had prior eyelid surgery or have other eyelid abnormalities, the degree of their facial rosacea, etc. We also look at the fluorescein breakup time, and we estimate that with being less than 10 seconds abnormal. We look for any seborrheic blepharitis or any foam in the tear film. Then the doctor's exam after beginning the lid touch is to begin looking for corneal staining using usually both rose bengal and fluorescein stain, and if appropriate, lissamine green. We look for conjunctival staining. We look for superior limbic keratoconjunctivitis. We look for the lid wiper, which is Dr. Korb's note. Patients in the averted upper lid exam may have this callus-like aspect to the lid margin posteriorly that can be very irritating to patients' eyes and would require additional treatment. We look for the meibomian gland expression of the lower lids and upper lids using that little plunger device that the company provides. We look at the Mark's line of the lower lids and grade it. We look at the Mark's line of the upper lids and grade it. We do the light test to see if there's any lag ophthalmos while somebody might be sleeping, and transillumination of the lower lids at least and upper lids if it's easy to get some idea of meibomography. We make notations of all this, and special tests could include a goggle test as well as a cold expression of the meibomian glands that might be using a Mastrada paddle or a Q-tip or what might just be a firm finger. Lip of view gives a number, average ICU, that's also documented. We also look at the blinking and the amount of partial blinking. We then approach the dry eye evaluation sample where there's a chief complaint, a speed score marked, the lip of view results, partial blinking additionally noted as to how many per, so if they did 5 blinks, if it was 1 per 5 or 5 per 5. We also look at right eye and left eye from the meibomian gland expression. We note whether temporally, centrally, or nasally there's inspissated, cloudy, or clear discharge from these glands. We give a total meibomian gland score. We add additional notes whether there might be waxy plugs or heavy cold expression with some waxy discharge. We also look at the meibomian gland structure via transillumination and get an impression, how much truncation or atrophy, the amount of dropout, the amount of dilated glands, and the number of remaining glands. We do some eyelid debridement, typically using the little golf stick. This is done if we are going to be doing LipiFlow, and then if LipiFlow is done, that also is mentioned. The plan is then noted. Additional light test can be additionally recorded, particularly if there is any degree of minimal, moderate, or dramatic lighting noted on transillumination through the closed lids. We also provide a fluorescein breakup time, the scoring on the meibomian glands. The line of marks is noted and posterior blepharitis is noted. So that would also be fairly straightforward. Whether there's no obvious meibomian gland disease versus obvious is also noted. The patient is asked to sign a consent form for the LIPA flow if it's to be done, and then there is a summary of the recommended dry eye treatment for the patient. That summary can include a wide range of treatments available, and in this particular instance, additional warm compresses, some blink closure exercises, whether they use a humidifier, what type of teardrops that they might use as a supplement, along with what ointment at nighttime, steroids, azosite, doxycycline, whatever other treatments might be provided, as well as the supplements of the omega-3 oils, etc. That would conclude the basic evaluation, although it is not uncommon to include a Schirmer's, may include a tear lab osmolality function, and any additional ancillary information should also be included at the time of the evaluation. Thank you. This concludes the documentation.